How to achieve the critical view of safety during laparoscopic cholecystectomy is demonstrated in this video. Procedure is performed using standard 4 ports method with port position as shown. Patient lies in supine position, and the surgeon operates from the left side of the patient. Epigastric port is placed under vision after creating pneumoperitoneum. Then right lateral port is placed. Gallbladder is retracted towards patient's right shoulder. Right subcostal port is placed. Necessary adhesiolysis is performed if required for complete gallbladder exposure. Before starting dissection in the Calot's triangle, important anatomical landmarks are located like the Rouvier sulcus, cystic node, segment 4B base, umbilical fissure, and the R4U line. The Rouvier sulcus is absent in this case, but right hepatic hilum can be seen. The R4U line passes across the hepatic hilum along the base of the segment 4B till the umbilical fissure. Cystic node and cystic artery are localized before starting dissection. Once anatomical landmarks are assessed, Calot's triangle dissection is started. It starts posteriorly. Only superficial dissection is performed initially. Similar dissection is performed on the anterior aspect. This allows initial identification of the cystic duct and artery, although they are not completely dissected at this stage. Peritoneal layer on posterior aspect is divided along the gallbladder towards the body. Hook cautery is used in this case, which can be used for blunt dissection also before dividing the tissue. Gentle elevation of the peritoneum and side-to-side movement of the hook tip allows CO2 gas to open the tissue planes. Peritoneal division is continued towards the fundus as far as possible, but the gallbladder is not completely separated from the liver. This step is facilitated by CO2-induced pneumodissection, as can be seen in video. Dissection is now performed on the anterior aspect. For this, the gallbladder neck is retracted infralaterally towards right side. Proper neck retraction is a critical step for safe dissection in the Calot's triangle. Dissection in the Calot's triangle is performed by dividing the tissues bit by bit using hook cautery. As the dissection proceeds, a plane is created between the cystic duct and artery. Deeper dissection is now performed on posterior aspect. Dissection proceeds close to the gallbladder wall by dividing fibrofatty tissues bit by bit. Hook can be used for blunt dissection also. With ongoing dissection, a window is created in the hepatocystic triangle, which can be confirmed from the anterior aspect. Next step is cystic plate exposure. Cystic plate exposure is an essential component of the critical view of safety. To expose it from the medial aspect, gallbladder is retracted infralaterally, and peritoneal layer is divided along the medial gallbladder wall adjoining cystic plate. This is continued toward the fundus. Then dissection is performed in the gallbladder bed. Hook cautery can be used to divide the tissues and can also be used for blunt dissection. Dissection is gradually continued between the gallbladder wall and cystic plate, which is the correct plane. Once the cystic plate is adequately exposed from the medial aspect, gallbladder is retracted toward left and is also elevated for subsequent exposure of the cystic plate from lateral aspect. Now the cystic plate has been exposed adequately as seen from the posterior aspect, and as seen from the anterior aspect also. This completes the one criteria of the critical view of safety. Now the remaining dissection in the hepatocystic triangle is completed to expose and isolate the cystic duct and artery. Blunt dissection is performed between the cystic duct and artery to create a window. This window is widened with gentle and gradual dissection. Remaining tissue strands between the cystic duct and artery are gradually divided with hook cautery. Basic principles of safe use of energy sources are followed during this step. Gradually a wide window is created between the cystic duct and artery, and both the cystic duct and artery are exposed adequately. This completes the another criterion of the critical view of safety. Now the critical view of safety is assessed by looking at it from two different directions, which is known as the doublet view. For anterior view, gallbladder neck is retracted infralaterally towards right. As shown, the hepatocystic triangle is adequately dissected and segment 5 could be seen across the window. More than 1/3 of the cystic plate is exposed, and only 2 tubular structures are now seen attached to the gallbladder. For posterior view, gallbladder neck is flipped toward the umbilical fissure, and CVS is assessed again. Segment 4B can be seen across the window created in the hepatocystic triangle. Based on both the views, it is now confirmed that all 3 criteria of the critical view of safety are fulfilled and a good quality CVS has been achieved. With the conclusive identification of the cystic duct and artery, it is now safe to proceed with clipping and division of the cystic duct and artery. Cystic artery is first clipped and divided. Cystic duct is then clipped and divided. Final step is gallbladder separation from the liver. Adequate gallbladder retraction is necessary for dissection in the correct plane. Tip or heel of the hook cautery can be used to divide the tissues. Dissection should proceed close to the gallbladder wall to avoid breach in the cystic plate, which can cause bleeding. Gradually gallbladder is totally separated from the liver. Cystic plate is now checked carefully for any bleeding and bile leak, and cystic pedicle is checked for the integrity of clips on the cystic duct and artery. Gallbladder is extracted in a bag, and procedure is completed.